My name is Erin Donald. I'm a PhD student here at the University of Victoria working with Kelly Staj-Dahar. My clinical background is in long-term care and in home-based palliative care, as well as some hospice settings. I'm a graduate of Ryerson University and then of Seattle University, and I did a scoping review on end-of-life care for persons with severe persistent mental illness that I'm going to be presenting the findings to you today. There we go. So what is severe persistent mental illness? Well, there was a similar review done by Woods in 2005, and I decided to go with some of the major tenets of how that group defined a severe persistent mental illness. I was interested in groups whose mental illness was prolonged and recurrent. So there is, for example, a lot of literature on people who were diagnosed with major depression after they were diagnosed with cancer. I was looking for someone whose experience with a mental illness predated their terminal diagnosis, that they're dealing with impaired ADLs, that there was a requirement of long-term treatment. And in the literature, most of the diagnostic groups that are considered to be severe and persistent are schizophrenia, schizoaffective disorder, bipolar disorder, and major depression. The prevalence in Canada is, no, I can't see my notes. The prevalence in Canada of these diagnostic groups, and this is so for the prevalence for schizophrenia, for bipolar disorder, and for major depression, since schizoaffective disorder was not measured independently, is between 4.6 to 5.5% in any given year. So definitely people that we're going to be seeing in our population groups. So why is this important? What makes this a special group in regards to healthcare? Well, this is a group that suffers disproportionately from more chronic diseases, a greater severity of disease. There tends to be late diagnosis. People with severe persistent mental illness receive fewer medical treatments and poorer quality care than the general public. They tend to die prematurely from medical illness, and at least in one Canadian study, are less likely to receive palliative care. The aim of this scoping review was to determine the extent, range, and nature of research activity about persons with severe persistent mental illness approaching end of life, and to identify gaps and opportunities for future research. So the key characteristics of a scoping review: it's a systematic search. I used the Arksey O'Malley framework. So there are several goals for this review. They list 5 goals for a scoping review, and this review met 3 of those goals: to examine the extent of research activity, to summarize and disseminate existing findings, and to identify gaps in existing research. And also to look at sort of the extent and range of what's out there, to get the lay of the land, to find out what's being talked about and what's being said. As such, a scoping review doesn't have a quality analysis. It's not designed to inform decision making. It's just designed to sort of get a feel for what's out there. The Arksey O'Malley framework uses iterative inclusion and exclusion criteria. So as you're going through the studies, you're figuring out what to keep and what to get rid of, which helps you define the scope of the review during the work that you're doing. You do an analysis by charting the data and by performing a narrative review. So you're really looking at the story of what the data is telling. I grouped my search terms into 2 sort of concept clumps. I had my end-of-life concept clump, and I had my mental illness concept clump. When I first started doing the searches, I was only looking at everything on the left-hand side, palliative to terminal, along with mental health and mental illness, but I realized that I was missing things by not bringing in specific diagnoses, which is where I went back and said, okay, what are the major diagnostic groups and how do I want to include them? So there was a search 1 and a search 2 when I went back and searched by diagnostic groups. I did not do sort of pilot searches ahead of time in the second search setting with the diagnostic groups to get a sense for how those search terms were working, and that is definitely a learning I have taken from this, and would advise for anybody else to go ahead and do that, even when you're just making minor tweaks to your search terms. because the terms schizo and bipolar are used very differently by molecular biology, and I ended up with a study pool of about 3,000 studies, most of which were from that field, to go ahead and sort through. Something I would do differently next time. Here are some examples of sample inclusion and exclusion criteria. This isn't an exhaustive list of what was there for the study, but I really was looking for the SPMI in relation to end-of-life care, that being the core theme of the study. The SPMI or disease had to be determined by the author of the study. So if someone didn't include specific diagnostic criteria or they didn't include specific diagnoses, I said, okay, whatever you're talking about, we're going to include here. The SPMI, as I said, had to be persistent. The onset was pre-terminal diagnosis. Studies on medically assisted dying, I found, did not really talk about end-of-life care. They didn't end up getting into the theme, the sort of intersection of mental illness and care that I was looking for, and so those were excluded. And transplant cases were an example of an exclusion criteria as well, since they dealt with kind of some different themes than traditional end-of-life studies. As I said before, I ended up with 3,143 original title and abstract reviews. Of these, 29 stayed. I picked up another 5 from the search of the reference list for 34 as a final set. Now, there was no date limit on this study, so this is 34 out there in the, I don't know, 13 or 14 databases that I searched. I used in vivo 10. I started with bucket coding, which is kind of like a manifest content coding. So I was just coding what people were saying about psychiatric care, what the intervention findings section said, what was the aim of the study, why were people doing that kind of work. Special populations might include people who were incarcerated or people who were in long-term care. And then I went back and I did a story level analysis of those buckets. So here are some descriptors of the studies I found, and sorry about the blurriness, I'm actually in the process of putting together my first poster right now and learning how to do these kinds of charts and data in Excel and use more graphics and fewer words, and you are all my first run guinea pigs. So this is an example of a pie chart of how the studies split up by study type. So as you can see, there were 8 descriptive studies, 9 case studies, 8 literature reviews, nothing like a systematic review. We're just kind of not there yet. There were 6 articles that were intervention articles, but they reflected only 2 intervention studies. So in all of this time, search without a time limit in all of these 34 articles, we only saw 2 interventions. Most of the articles looked at all severe persistent mental illness. Where there was a specialist disease, 1 study looked at major depression, 11 studies looked at schizophrenia. There were no studies that looked at schizoaffective disorder or that looked at bipolar disorder independently. Most of this work is happening in mental health journals. So palliative care journals are publishing about it, but people in mental health, that's where the publications are happening about end-of-life care. Once again, most of the publishing happening in the USA and then sort of split amongst the Commonwealth countries, with some studies being published in Europe. For professions, this was profession of first author, so we had mostly MDs. We had 7 nursing studies going, so that was encouraging to see. Social work is also very involved in this, and then we had a few from biology, actually. For year of publication, so we've definitely, so the earliest study was 1991, and all of the studies up to 2004, there were only 6. And since 2005, there have been 28 studies, and those are divided pretty evenly between 2005, 2010, and 2010, 2015. So the field has certainly picked up in the last 10 years. So getting into the findings, what did the studies actually say in that narrative review? One of the major themes that came across was complexity of care. So this was a population that was overwhelmingly complex. They had this medical complexity, they had these chronic diseases, they had these different, increased likelihood of adverse effects after surgery, like just complexity sort of coming from all directions. And then you really got into the interaction and the overlap between the psychiatric conditions and the medical conditions. And so trying to sort out whether you were you seeing psychiatric symptoms, were you seeing medical symptoms? Did it have a psychiatric etiology? Did it have a medical etiology? What treatments were gonna be best? Was treatment from some kind of medical disease affecting a psychiatric condition, or vice versa? How were the medications interacting? And what was causing changes during decline, and also changes during decline. So, for example, medical changes during the decline towards end of life might be affecting the way that somebody's psychiatric medication is being metabolized, and how did that work out for their psychiatric illness and for their experience. With symptoms, often someone with a severe persistent mental illness has special care needs. It just takes kind of a higher level of knowledge to be able to really intervene with that, to be able to navigate this complexity. There may be behavioral issues. So, for example, if someone is a frequent smoker, they might not be able to be housed in a hospice that doesn't allow people to go out and smoke. What are some of those issues there? Lifestyle factors also involved, similar to smoking, but also lack of exercise, those types of things that are going to be affecting both medical illnesses and psychiatric illnesses, and that may be contributing to symptoms during decline. For setting, people with a psychiatric illness may already be seen in a particular setting if they have a relationship with their local psych unit, or if they have a relationship with their caseworker. Moving into an end-of-life care setting may sever those existing relationships. You may no longer have access to the care providers that they have built a relationship with, and also whether or not each setting can work on meeting individual needs. If someone is actively hallucinating, can their needs be met in a hospice? Where can their needs be met, if that is the case? And of course, compounding this complexity, you have this overwhelming burden of stigma and discrimination and social disadvantage, like isolation and poverty, and a society that is sort of stacked against people with mental illness. And you also have the complexity that you pull in when you're looking at people who are homeless, or who are incarcerated, or who have been institutionalized. History of abuse would be another one that would influence complexity of care that you see at a much higher rate in this population. Access to care became a big theme, and there are two sort of components to that. One is the system component, and one is the healthcare provider component. So in the system component, you have everything systemically that's contributing to a late diagnosis, and then everything systemically that happens to you as a result of being diagnosed late, whether that's crisis admissions or those kinds of things. We're seeing specialties, like a really huge theme was the siloing between mental health and psychiatric care, or the separation of psychiatric care from general care, and how these different teams could get together, how these different providers could get together, how separated they were now, and how much of a disadvantage that was in caring for people with severe persistent mental illness. There are different guidelines, so ethical and legal guidelines. Institutional guidelines may help or hinder. Legal guidelines may help or hinder. Once again, we've talked about setting capacity, whether or not the setting can handle severe end-of-life needs if it's a psych setting, or whether an end-of-life setting can handle psych needs. Being bounced around from different settings, and you may see this, for example, in someone whose needs can't be met on a medical unit because they're psychiatrically active. They'll be bounced to psych, but then psych says we can't handle this medical complexity. They might be bounced back to medicine, which is going to just fracture care and contribute to that siloed aspect that we talked about before. And of course, you have discrimination that can really be entrenched at a systemic level, whether there is, so for example, someone seeking emergency room care, if there is no quiet or low-key or low-distraction place to wait, can be an example of a systemic situation that can be really unhelpful to people with SPMI and their particular needs. And of course, the previous experience in the healthcare system. If someone with an SPMI has had a poor experience previously, they may not be willing to seek care, or they may not be willing to cooperate with care in the same way. Talking about siloing and lack of services from a system level, it's important to note that there was one study that was done in the VA that showed that people with schizophrenia had equal or better access to palliative care compared to people in the general VA population. So that was very encouraging to see. But it's also important to note that the VA is a very closed system. So they are a single payer system. They sort of, I can't think of a better term for it, but they sort of keep track of their patients from different care provider to different care provider, and so that was a system where people were having some good outcomes. Although, of course, it's important to also note that people who weren't seeking active follow-up or who weren't engaged in active follow-up were not necessarily captured in that study. Healthcare providers present their own challenges. Often there's a lack of training on how to deal with people with severe persistent mental illness, the same way that we've seen issues with there being a lack of training or a lack of awareness around dealing with end-of-life issues. Providers all over are challenged by that for these different sort of special needs areas. There may be an avoidance factor due to unfamiliarity with mental illness or to active behaviors or symptoms that people are finding difficult to deal with. Providers may avoid that. They may want to get in and out as quickly as possible, for example. And of course, none of us are immune to stigma. Stigma is pervasive in society, and we see that in providers as well. Another theme was around competence and autonomy. So a lot of researchers talked about competence and autonomy, and actually one of the two intervention studies was looking at advanced care planning and discussing end-of-life preferences with people with severe persistent mental illness. It's important to note that autonomy is not a right. There are exemptions to autonomy. We only grant autonomy to people who can prove capacity and whatever we determine that capacity to be. So whether that's a tool or whether we determine it in an intake interview, however we have those conversations or those interactions that lead us to say this person's competent to make their decisions, there's the possibility that you can be deemed incompetent in that. And for people with a severe persistent mental illness, there is a presumed incompetence, and that's coming from both researchers and from healthcare providers and from the system. For someone with a severe persistent mental illness, capacity can be fluctuating, and so that creates, if you want to work within that fluctuating capacity, that creates a sort of special setting where you need to kind of catch someone at the right time or be able to be flexible or be willing to be flexible, to have those conversations, to keep track of those conversations, to have those conversations, to have documentation of those conversations, and move with the person around all of their different care sites. You can see how many opportunities there are for that falling through the gaps there. And there are challenges with proxy decision makers. People with severe persistent mental illness are often socially isolated. Their family members may be absent or distant. They may not have close friends who are able to act as proxy decision makers. The closest people in their lives may be healthcare providers who are not eligible, or they may have legal guardians who have their own mandates about how to make choices that may or may not be based in what the person wants or would want. Were they able to express it? Few people with SPMI have advanced directives. With healthcare providers, there can also be like a fear of the reaction that talking about end-of-life work is really going to distress someone, or it might trigger a relapse, or it might affect their mood. The study that did sort of the several phase looking at advanced care planning and having end-of-life planning conversations with people with severe persistent mental illness found that those conversations were not distressing, and we should not be afraid to have them. There are similar priorities in end-of-life care compared to the general population. So people want to be treated with dignity. They don't want to suffer. And there are other ways. There is a need for customized decision-making, whether that's customized tools to work with a particular population, or whether for someone who's been deemed incompetent to then use consensus-based decision-making as opposed to straight-up proxy decision-making. Mental health and palliative care were considered to really really share philosophies, to have this emphasis on symptom management, on quality of life, on relationship-based care, and there were a number of studies that talked to different care providers who said, you know, we can't understand why we can't get together, that the opportunities for collaboration are ripe, that everybody's on the same page, cross-training, cross-consultation, working together on the same healthcare teams. All of these are ways that palliative care and mental health can bring their expertise together. From a discussion perspective, what we really saw doing this work is that this is an incredibly vulnerable population. Between the medical complexity and stigma and the discrimination, the likelihood that someone may be incarcerated or institutionalized, that there was this presumed incompetence when someone would enter the healthcare system, all of these barriers. You know, you look at issues like late presentation. Is it really late presentation, or is this where or did someone present earlier and it just wasn't caught? Did someone seek help earlier and they just weren't able to get the help that they need? This is a population that is vulnerable above and beyond the vulnerability already suffered by patients and families at end of life, and that they had been suffering for this vulnerability for years before getting to this point. Whose voice was privileged in this body of research? Well, it was researchers and it was clinicians. A lot of the work, so remember the number of studies, you know, that were literature reviews, for example. You're looking at researchers asking researchers what they think. The clinicians were, when there were primary data sources, they tended to be clinicians. Very few people with severe persistent mental illness were represented in this literature. There was very little present for leadership. There were sort of broad discussions about, well, you know, the system should work more together, but very little for managers or for policymakers or for leaders about how to make that happen. Woods, as I mentioned, did a very similar literature review, or did a very similar review in 2008. What I found in this review was that the themes were very similar, the findings were very similar. So although work is continuing to be published in this area, we're not really making a lot of forward movement. We're not developing greater depth or complexity in the field. And it is interesting to note that while the vast majority of studies considered mental illness to be a pathological, biological condition, there was at least one study that talked about hallucinations or delusions as a potentially useful way to work through end-of-life conditions. And there were another set of studies that that sort of challenged the biomedical, you know, seat in the biological brain idea of mental illness. And so these sort of, there is some flux and some conversation going on out there about what this means. Researchers from the studies that were looked at here were really very much in favor of palliative care and mental health working together. So forming partnerships, integrating, collaborating, consulting, doing cross-training, and embedding, so for example, taking like a mental health nurse and embedding her within a hospice, those types of situations. Healthcare providers really needed to be aware of that complexity. They needed to know the symptoms and know how to react, so sort of have some baseline understanding of what a severe persistent mental illness might look like, and sort of have some reactions and some tools in the toolkit for how to work with that. To really be alert to changes and to be sort of open-minded or aware about changes that a medical change or a psychiatric change may indicate a change in a psychiatric illness or a change in a medical illness. If that makes sense, you may have a psychiatric change that could be indicating that there's a medical change going on, or vice versa. To really treat the patient with respect, so treat them with autonomy, take time to build relationships. For some people, for example, who have a really flat affect or who aren't making eye contact, it may feel unnatural to try and build a relationship with that person. It may feel like you're not getting anywhere, but you need to try, and you need to be working to build that relationship, even if the situation is something that you're unfamiliar with or you're seeing active symptoms. Developing those therapeutic relationships and making use of the whole healthcare team. So if you have mental health people or if you have end-of-life people on your healthcare team, to go to them. If you have a spiritual concern, to go and make use of the chaplain, access that person. Not that it's a psychiatric patient, so it needs to be psych, or it's an end-of-life patient, so it needs to be end-of-life, but to really branch out. Reducing siloing in all specialties in general care, so more access to palliative care knowledge and more access to palliative care expertise and more access to psych knowledge and psych expertise for everybody. Ensuring access to care, and so this was something that we see extended from, these challenges of access to care for people with severe persistent mental illness throughout their lives needs to extend as they are approaching death. You really need to make sure that you're still looking at these access issues and saying, we need to remove these, we need to be getting these out of the way. To collaborate with existing sources. So for example, street nurses, sort of ask yourself, where is my population? Where are people with SPMI who are dying? Are they on the street? Let's work with street nurses. They are already in with this population. How can I work with providers who are already at points of access, and to just choose, yes, I actively engage in end-of-life conversations. And of course, everybody called for more research to develop the field, to pay attention, to address neglect. These were terms that came up in the aims of the studies. There was definitely an acknowledgement that there isn't a lot out there and that more attention needs to be paid to this field. To identify the place of care at end of life. So this was something that came out of a number of studies, but there was a study particularly that was done in Canada by Harvey Chochinov that looked at place of death for people with schizophrenia and found that a lot of care for people with schizophrenia at end of life was happening in long-term care facilities. May not be well or widely known. To know how to access this population, we need to know where people with severe persistent mental illness are dying. Looking at research that's going to overcome barriers, that are identifying strategies, that's asking what's happening now, so a little more descriptive work. To recognize the heterogeneity of the population, so that not all persons with SPMI are alike, or studies that reflect people with schizophrenia don't necessarily reflect all persons with SPMI. And more work around advanced care planning. From the researchers, so this is the recommendations that I have after taking a look at these studies, are that we definitely need more research targeting system issues and roles for leadership. There was very little, other than palliative care and mental health working together. There wasn't really anything that was challenging or looking at these system level barriers. To conduct really high quality qualitative and quantitative studies. So there's a lot of descriptive work going on, there's a lot of literature reviews going on, but we really need some high quality work moving forward. Where there have been successful interventions, we need to follow up on that, look at integrating those into other settings, seeing how they work with different populations. And of course, to engage with a palliative approach, because the embedding of the principles of palliative care goes hand in hand with increasing access to palliative care for this population, particularly as it's a specialty population that's being cared for in specialty settings where end of life may not be as present or be reflective there. And to involve people with severe persistent mental illness in research. There were very few voices of people with SPMI in this work, and when we look at presumed incompetence, we as researchers need to be mindful of that as well, and to work with ourselves as researchers, with our teams, with ethics committees, and say, no, this is a valuable population, this is valuable insight, and we need to be able to work with these people.